Hi everyone. Today we're going to start with course E4A, Power, Positioning, and Electronics. Course objectives are to learn the definition and coverage criteria for power positioning systems. That's the power tilt, the power recline, the power elevating seat, and the power tilt and recline. We're going to learn about the coverage criteria, the benefits of it, the justification, and so on. So let's jump right in. We're starting with power tilt seating system. You should have these handouts in front of you. The code, you're going to get used to these codes because there's not that many powered seating codes, and you'll get more and more familiar with them. There's tilt recline, there's recline only, and there's the seat for all. Power tilt seating, system HICPIC code E1002. Included in this code are the following items: the ability to tilt greater than or equal to 45 degrees of horizontal, ability to support the patient's weight of at least 250 pounds, includes any frame width and depth. That means if the patient is wider than 22 inches, wider than 20 inches, deeper than 18, 20 inches, there's no additional reimbursement for a power tilt that's deeper than 20 inches. There's no additional power tilt that can accommodate a weight of more than 250 pounds. So it's all under E1002. It doesn't matter the patient's weight. It doesn't matter if the patient's getting a heavy-duty bariatric base, a extra heavy-duty, the actual seating system. It's going to be coded E1002, and that's what you're getting reimbursed for. The only code you're putting down and justifying is the E1002 if you're doing a tilt-only seat system. Includes any type of armrest, fixed or swing-away detachable leg rests. And related electronics with or without a variable speed programmability. I mean, any electronics or the actuator that goes in for the tilt, even though we'll saw on the next slide about the electronics, expandable controls to accommodate the electronics, but this actual system you're not actually getting paid for the actual actuator. A motor and related electronics with or without a variable speed program, the same idea. A switch control, which is independent of the power wheelchair drive control interface. If you were to set up the tilt, where the patient, you'll see this on many chairs, the patient can have. They can control the drive with one hand, with a regular joystick, and that they want to use a separate non-through drive. We keep talking about doing it through the drive control, using the same joystick, changing the mode from seat to drive. Instead of doing it like that, you can have a patient that opts to have a separate switch that they tilt their chair with. They can have like a little button on the right side. They can use their elbow to do it instead of actually going out of drive, play with the seat, back to drive, play with the seat. They're able to stay in their drive mode on their regular joystick and have a separate switch or joystick or some sort of mechanism interface to work the tilt seating system. Any attach the seating system. So there's any of the brackets where they tie down the tilt seating system to the base, that's all included in your code for E1002. This does not include a headrest E0955. Just to give you some understanding what that means, whenever you have a patient that their seating system is going to put them in a posterior position, meaning if they're going to be tilted or reclined. So tilted, they're going to kind of rock back. As soon as they're going backwards, tilt or recline, they're going to get justified and they're going to qualify for a headrest. The reason for this is the headrest is not there to hold the patient's head up. The headrest is there to catch the patient's head. So when the patient goes into a posterior position, whether it's tilt or recline, they don't have to strain their neck to maintain their head looking forward. They don't have to feel uncomfortable. The headrest is an additional component coded E0955. It's there to catch the head. Now, most of the times you'll get another code as well, miscellaneous hardware code. We touched on that briefly, E1028, the E1028. That is a miscellaneous hardware code that'll usually attach the headrest to the back of the backrest. It's a removable headrest. You can remove the headrest if they're transferring the patient and they want to use like a Hoyer lift and someone's got to get behind the patient to pull them up. The headrest is in the way. You could remove the headrest without getting totally sidetracked. There are a lot of items that are included in the tilt. The headrest itself is not. Now, Power Tilt Seating System HICPIC code E1002 Medicare coverage criteria. Now we know what's included in the tilt. How does a patient qualify for a tilt? Why would the insurance provide tilt for a patient? Why would you recommend it for a patient? So coverage criteria 1, 2, and 3 are met, and then either one of 4, 5, or 6 are met. So just going through it, number 1, the patient meets all the coverage criteria for a power wheelchair. And there's a specialty evaluation performed by a PT or OT or physician who has training in rehab wheelchair evaluations. So now, again, we're talking about CRT. So any complex rehab chair that we're going to really discuss in terms of ATP and doing something custom is always going to need 2 and 3 because we're talking ATP custom wheelchair. So if you have a patient who needs just a very basic group 2 patient with COPD, they're unable to get down a long hallway, they need a group 2 power chair, no custom seating, that is not considered CRT. And technically, a doctor can do all the justification in a face-to-face. To operate it like that, because the doctor's face-to-face, if there's not going to be a therapist letter of medical necessity in conjunction with the doctor's chart note, the doctor really has to do a proper face-to-face. They have to go through money and muscle scores, what happened when trial, the ADLs. They'll have to give Medicare the full objective picture of the patient. Objective measurements for strength, trial cane walker, why can't they use it, how's their balance, whatever we're going to do in our letter of medical necessity, the doctor needs to do that in their face-to-face. If they're not recommending custom, the doctor can do that by itself. So when we say that you need to have the PTOT and an ATP, any chair that starts from above K0835, that was our group 2 with power tilt seating system, that's your lowest code in CRT, or any group 3 power chair, even if it's static seat, it's a captain van seat on a group 3 base, that's considered custom. You're required to have a PTOT and an ATP, PT or OT and an ATP. So any chair we're going to discuss right now, the patient has to meet the coverage criteria for a parent wheelchair. That means there's some ADL in their home they cannot accomplish because of their mobility limitation. They can't use a cane walker, manual wheelchair, or scooter. They're able, willing to operate the power wheelchair. They have a PT, they have an ATP, and now we're going on to putting the seating system on it. So back to the actual tilt criteria. So we already obviously have to justify a power base and a custom power base because we're putting tilt on the seat. The patient is at high risk for development of a pressure ulcer and is unable to perform a functional weight shift. One reason why a patient would benefit or qualify for a tilt and space power tilt seating system is the patient is unable to perform an effective upper body weight shift. That means they're unable to fully rock right and left or do a full wheelchair push-up. Sometimes a patient will ask them how they transfer, and they think they could. They're not sure. They're rocking, but you have to know based on the patient's weight, are they really effectively weight shifting or are they not? But in any event, if the patient is unable to perform a functional weight shift, they would then benefit and qualify from power tilt. Number 5, the patient utilizes intermittent catheterization for bladder management and is unable to independently transfer from the wheelchair to bed. So we have a patient who needs to change his position to change his catheter, and they're unable to independently transfer from their wheelchair to their bed to kind of go into a supine position to change their catheter. So what we do is they can stay inside their chair, power tilted back, change their catheter in that supine position. They have even they're just tilt, they're kind of like 45 degrees back. Let me see my hand like that. There we go. It's kind of backwards in the mirror here. But if you can picture the patient seat to back angle is staying the same, but their entire center of gravity is going backward, they have a better position to change their catheter. At number 3, power seating system is needed to manage increased tone or spasticity. Many patients that have increased spasms, they'll find that when they're in supine, they're laying down, the spasms is less prone to come on. When th're sitting up in more of a dynamic position, that's when they go into strong spasms. But if they're sitting back, it kind of lets their toe muscle relax. So again, that would help them just to manage their spasms. They need to tilt their chair back very often, therefore they would qualify for tilt. Just to give a little background here, I'm not sure if I discussed this earlier, you should know the difference, and it's important to know the difference, but we're talking about 3 different types of powered seating here. There's power tilt, power recline, power elevating seat. Power tilt is your patient is sitting in a seat system, their entire seat pan tilts backwards. So what's going to happen is after they can go as far back as 45 degrees, like we said, and what happens is your patient's back to seat angle doesn't change. Their hips don't open up or close. Their seated posture stays the same. If they're sitting at 90 degrees from from their back to their hips to their knees is 90 degrees. They will stay 90, 90, 90. Just their entire seat kind of rocks back. Recline is the patient's lower extremities stay where they are, and the backrest goes backwards. So what happens is the backrest opens up, and the patient's hip to back angle opens up and goes into an extension. That's recline. So you have power tilt is where the patient's actual seated posture does not change. Power recline is where the seated posture does change. Now, once they're reclining, any patient with more than even 120 degrees of recline, they already should start lifting their leg rests. This is something, it's a little off the actual course of E4A, but it's important to note when a patient goes into recline and they start opening up their hips, they're going to start sliding in their chair if their leg rests aren't coming up. If they're not elevating their legs to make sure they're not sliding forward, they're going to start sliding. So when we go into recline, you're going to see that if a patient has power recline and they've justified power recline, they can also justify elevating leg rests, motorized elevating leg rests if they have motorized power recline. In regards to tilt and recline, I'll get to this in just a second here. Power recline seating system, HCPCS code E1005. This includes the ability to recline to greater than or equal to 150 degrees for horizontal, and what it is found, we said before 45 degrees, and now we're saying 150 degrees. If you're going to do tilt only for power, for pressure relieving activities, you need to go back to 45 degrees to get a proper redistribution of the weight. What's happening is you're tilting back, you're changing your center of gravity, and with that change of center of gravity, we're now having a pressure relieving activity. If you're going to do tilt only, you need to go back to 45 degrees to get proper pressure relieving activities. If you're going to do recline only for pressure relieving activities, you got to go back to 150 degrees. However, the University of Pitt, I mentioned this a few times because it's one of the things I promote a lot, is tilt recline combination. If you're going to offer a patient with tilt and recline, the combination of doing tilt recline, if they can go up to 15 degrees of tilt as opposed to 45 degrees. So just 15 degrees, it's not that severe. And 120 degrees of recline, again, that's also not very severe. Most of us sit at 95 or 100 degrees to start. Be the optimal redistribution of weight. So moving right along over here, we have the power tilt, we have the power recline. Now the power recline justification is going to be the exact same as the power tilt. So what we say included in the E1005, same sort of concept, the ability to support a patient's weight of at least 250 pounds, meaning if the patient weighs that much, it's ability to support a patient's weight means if the weight capacity on this recline system is only 100 pounds, it's not going to get coded E1005. It includes any frame width or depth, meaning if the patient is super wide, super small, it's not going to change the code. The code will stay the same. There's no additional codes to pay for that. Sometimes manufacturer might charge us more for extra wide or something. There's no additional reimbursement for that. It includes any type of armrest and fixed or swing away detachable leg rests, a motor and related electronics. All the electronics that go into everything is included under the E1005. Your entire package of power recline, like we had before, your entire package of power tilt, it's all included in the code of E1005. Again, any hardware to mount it to the base, that's all included in the code.